So last class we started talking about breast cancer, and we said that it is basically a neoplastic transformation of the mammary epithelium. We discussed the structure of the bilayer of a mammary epithelium, and we discussed the main subtypes, molecular subtypes of breast cancer. And we also described the risk factors, and we said that the risk factors are either modifiable, like some lifestyle factors, or non-modifiable, like the family history, genetic factors, and reproductive history of a patient, and so on. Now, signs and symptoms, very important, and actually this is part of spreading awareness to women in community. They need to know when to suspect malignancy, okay? And by this, they can actually seek medical help or attention. So a very important and usually a classic finding in breast cancer is the presence of a lump or mass. This is usually palpable, okay? And المريضة إذا بتعمل self-exam, breast self-exam, she can feel a mass, a lump. In majority of cases, classically, this is painless mass, not painful, okay? So a classic finding is a painless lump, okay? Usually 90% of breast cancer cases, the patient will detect the presence of a lump, okay, or a mass. It can be in the breast area, it can be sometimes underarm, okay? A lump is very typical finding. Now, sometimes there are changes to the breast itself, like swelling, erythema, okay? Sometimes changes to the nipple. We can see changes to the nipple, like inversion, retraction, discharge sometimes, or bleeding from the nipple, and so on. So if a woman is doing regularly breast self-examinations, which we will talk about when we talk of prevention and awareness, she becomes familiar with her breasts, okay, and then she can tell if there are abnormalities or changes, okay. فالكاركترستيك findings هي بتكون عادة موجودة أو limited للbreast area. Now, sometimes if the neoplastic tissue or the disease has spread to distant tissues, okay, ورح نحكي about metastasis. Some symptoms might be because of the metastatic involvement. يعني مثلا في كتير حالات breast cancer patients, they come and they complain of pain in the back, bone pain, shortness of breath. Sometimes we do labs and we see elevated liver enzymes. Usually these symptoms because of the disease metastasis, okay? فأحيانا ممكن يكون في symptoms because of the metastasis rather than the primary tumor. فلما إحنا بنقول breast tumor or breast cancer, we are talking that the abnormal cells, the malignant, the neoplastic, the cancerous cells, the primary site, they start in the mammary epithelium, okay? And if there is metastasis, they have moved to a very distant tissue, okay? فبالتالي لما بنقول breast cancer احنا بنقول انه the cancer cells start or the primary organ is the breast. If we talk about colorectal cancer, the primary organ is the colon or rectum, and so on, okay? هلا, sometimes we have what we call it biomarkers, tumor markers that we can measure, okay, in blood. They can correlate sometimes with the diagnosis or mostly with prognosis, okay, how the case is going. فإحنا في عنا two markers that we can usually check for patients who are suspected to have breast cancer اللي هم cancer antigen CA 27, okay, and carcinoembryonic antigen CEA. These could be elevated. هلا لو ما كانوا elevated, if these two are not actually elevated, this does not rule out malignancy, okay? When we talk about diagnosis of breast cancer, the patient comes with a clinical presentation or symptom suggestive of breast cancer. The definitive diagnosis happens or comes when we take a biopsy of the mass and then check it in pathology whether this is neoplastic or not, okay? هلا, let's take a very typical case, classic case of a patient with breast cancer. Mostly the patient will come surgery, okay, clinics complaining of a symptom. خلينا نقول classically المريضة بتيجي بتقول I noticed إنه في discharge, في changes in the nipple, or there is a mass mostly. Okay, this is the complaint. A mass in the breast is not always cancerous, is not always malignant. يعني مو دائما أي مريضة عندها breast mass palpable it means this is a breast cancer. Okay, sometimes it is benign, it is a fibrocystic disease, okay, or fibroadenoma, but there is a mass. فلما بيكون في mass, okay, clinical presentation suggestive of breast cancer, we have to rule out or confirm breast cancer. فلما بتيجي المريضة بتقول إنه في mass, okay, we usually do ultrasound or mammography to locate the mass and look at the mass. Sometimes الماموغرافيك findings يعني كيف بيجي شكل الماموغرافيك picture أو image, you can tell if this is cancerous or not. يعني عادة بيكون في calcification, irregular mass, okay. It can tell you, okay. يعني بتعطي idea. الماموغرافي أو MRI ممكن تعطي idea, but this is not final or definitive, okay. So to confirm a diagnosis of breast cancer, we must do biopsy, we must check tumor cells, we check the mass, and then confirm if this tissue is malignant, neoplastic or not. How to take a biopsy, how to take a sample, okay, of that suspected mass. We have 3 different ways to do biopsy. We call it fine needle, when we introduce a needle and collect some cells, okay, of that mass. Or core needle, and this is very common usually, and this is the standard, okay? So under the guidance of MRI, the pathologist will take a sample of the tissue, okay? This is a tissue sample. وفي عنا ال open أو excisional biopsy, يعني هذا مش كتير common, okay? We do a cut and take part of that mass, and sometimes the whole mass can be removed, and this is not that common. معظم المريضات بيعملوا يعني when we do biopsy, we mostly do it through the core needle biopsy. We take a tissue, okay, sample of the mass that is suspected to be malignant, okay, or whatever mass, to confirm whether this is neoplastic or not. Now, after we take the tissue is checked in pathology department with a consultant pathologist. The pathologist will tell in their report whether this is a breast cancer. وعادة they will give us the type of carcinoma. We will talk in a few minutes, the histologic type, the grade of the carcinoma, and usually they will do also assessment of the target receptors, اللي هم estrogen receptor, progesterone receptor, and HER2. Okay, فكل هاي المعلومات we can get it in the very beginning because we did biopsy. فالbiopsy كتير مهم لأنه the biopsy will tell us whether this is cancerous or not. Because if it is not breast cancer, we have different management. هلا لنفترض انه الداتا او results of the biopsy told us it was carcinoma, it's a cancer tissue, okay, it's a breast cancer, okay. Once we confirm it's a breast cancer, then we need to stage the disease, okay. But the staging is very, very important. Why? Because based on the staging, we plan the treatment. فإذا أنا to be able to manage a case of breast cancer, I need first to confirm a diagnosis of breast cancer. This is done in pathology. I need to know the molecular subtype of breast cancer, and also this data comes from pathology, and I need to stage the disease, okay? هلا بشكل عام لما احنا بنحكي staging in solid cancers, the most important staging system, we call it the TNM staging system. Okay, فلما احنا بنحكي TNM staging system, we look at 3 parameters. T means tumor size, N number of lymph nodes involved, okay, and M means metastasis, and here we mean distant metastasis. هلا الميتاستاسيس we have two types of metastatic disease. في إشي بنقول له distant metastasis وفي إشي بنقول له micro metastasis. هلا metastasis by definition means, the distant metastasis means that the primary cancer cells, which here are breast cancer cells, they will move or they will translocate either through blood vessels, hematological, or through lymphatic vessels, okay, to a separate and a distant site. هلا لما احنا بنحكي breast cancer metastasis, okay, في دائما لكل نوع كانسر في عنا target organs we know that they are commonly involved in metastasis. So when we talk of breast cancer, metastasis is usually, we find metastatic disease, if any, usually in the liver, in the lung, in the bone, and the brain, okay? هلا, in the very beginning, when I am staging the disease, I have to answer whether this is metastatic breast cancer or not. Why? Because the treatment is different. هلا الM تاخذ two values, O or 1. فإذا أنا عملت radiologic investigations, I did CT to the brain and CT to the bone, CT to liver and lung, and no lesions were detected in these four organs particularly, I can rule out metastatic disease. فبالتالي M will take a value of O. There is no metastasis, okay? إذا أنا ما عندي metastatic disease. لكن هذا لا يعني إنه ما عندي disease. Okay, the primary tumor in the breast is there, but it did not create or establish metastatic secondary tumor sites in these organs. فبالتالي بقدر أقول إنه this is non-metastatic disease. Okay. طيب, what if we did CTs or we did the radiographic investigations, and we found that there was abnormal lesions in the liver or in the bone, suggestive of metastatic disease. In this case, M will take the value of 1. فبالتالي, the presence of a lesion, even a single metastatic lesion, in any organs that are involved in metastatic disease means we have metastasis. Okay. بمجرد إنه المريضة عندها metastasis, regardless of T and N, regardless of their values, regardless of the tumor size or lymph node involvement, she directly goes or jump to what we call stage 4 disease. فإذا metastatic disease means advanced disease. كلمة advanced or metastatic imply إنه هاي المريضة is a stage 4 disease. Okay? هلا stage 4 disease has its own management. فعشان هيك ال TNM staging is very important. Okay? طيب, if we rule out metastasis, if this patient does not have metastasis, okay, then we need to give a stage. We have to look at the tumor size. We have to look at lymph node involvement. Okay, the lymph nodes. Do we detect cancer cells inside lymph nodes or not? في عنا chest or regional lymph nodes. في عنا axillary lymph nodes. Okay, and we have to know the tumor size. What is the tumor size? Okay. هلا لما احنا بنحكي عن the tumor size, في tumor size ببين معي من الماموجرافيك exam, والأدق منه اللي هو بنقول له pathologic tumor size اللي هو the measurement of the tumor dimensions after removal of the tumor mass with surgery. Okay. Generally speaking, كل ما زاد the tumor size, the prognosis is worse and the stage usually jumps up. هلا لما بيكون the tumor size very small, 1 or 2, يعني إذا أنا إجيت after مثلا surgery, let's assume I did lumpectomy, I remove the tumor, I send the tumor to pathology to examine the size. The pathologist will try to measure the largest dimension of the tumor. Okay, that is T. If T is below 2 centimeters, اللي احنا بنعتبرها هون in the size of a pea or peanut, okay, below 2 centimeters, then the tumor value is T1. Okay, إذا كان the size of the tumor is between 3 and 5, okay, that is T2. And if it is above 5 centimeters in largest dimension, which usually we tell the patient the size of a lime, okay, هذا احنا بنعتبره T3. فبالتالي the T can take values 1, 2, and 3 based on the largest tumor dimension. T4, if I tell you that this patient has T4 disease, it means that the tumor reached the skin, okay? And T4 disease or illness is considered really bad tumors. فبالتالي T tell me about the tumor size, okay? And tell me about lymph node involvement, okay? Simply, the pathologist will isolate lymph nodes, we'll talk about lymph nodes, and they will check whether there are cancer cells reaching lymph nodes or not. Lymph node positive disease means there are cancer cells in lymph nodes. And this is usually an adverse prognostic factor. فبالتالي, we can check lymph nodes, and it could be either N equals 0 or no lymph node contains cancer cells. وهذا بنقول له lymph node negative disease, okay? Alternatively, no, في عندنا lymph node positive disease, there is lymph node involvement, which means we found, okay, lymph nodes containing cancer cells. And based on the number of lymph nodes containing cancer cells, we give a value for N going from 1 to 3. فبالتالي, if I tell you that the patient has N1 disease, it means directly there is lymph node involvement, or this is a lymph node positive breast cancer disease, and the number of lymph nodes is involved with cancer cells is from 1 to 3. Okay, هذا معنى N1. If I tell you N takes the value of 3, it means more than 9 or 10 lymph nodes contain cancer cells. فبالتالي, when N gets higher values, it also implies a worse prognosis or a more advanced disease, more serious disease, okay? فلما احنا بنعمل stage, not المريضة staging from 1, 2, 3, or 4, we are talking about invasive breast cancer, we're talking about the T status, the tumor size, the lymph node status, and metastatic disease, whether it exists or not. طيب. هلا, if I did my CTs and I did not check any abnormal lesions in the organs commonly involved in metastatic disease, does that rule out any potential for metastasis? يعني can I be very, very, very sure إنه بما إنه أنا ما لقيت lesions, there has been no lesions at all in the screening, can I completely rule out metastatic disease? أو ممكن يكون في metastatic disease بنقول له micrometastasis. What does it mean? لما أنا بحكي micrometastatic disease, what does that mean بالsolid cancers؟ حدا بيعرف؟ شو يعني micrometastatic disease؟ حدا رافع ايده بده يحكي لي أنا I don't see ماني شايفة حدا رافع ايده، فإذا في حدا رافع ايده you can go ahead and talk.
دكتورة أظن إنه بيكون في cancer cells بنتقلوا من محل التيومر لمحل تاني إنه to another organ، بس إنه بيكون small collection.
Yes, very good. يعني إحنا لما بنقول آية right؟ فإحنا لما بنقول yes, good, thank you. فإحنا لما بنقول micrometastatic disease, there has been a spread of cancer cells from the primary site to a distant site, but in a very small count or number, and so the cancer cells were not detectable by the diagnostic procedures we apply. يعني keep in your mind إنه any procedure في لها detection limit or sensitivity, okay? فأنا ما شفت lesion واضحة بالبرين أو بالليفر أو باللنج. This does not mean there might not be few tumor cells in that organ, okay? فدائما في عنا potential إنه في micrometastatic disease. Okay, and keep that in your mind because this will justify, this provides rationale for systemic chemotherapeutic drugs, okay, to control micrometastatic disease, if any, okay, which the local treatment like surgery and radiation will not control, okay? ففي فرق بين micrometastatic disease and distant metastasis. If there is distant metastasis, if M is 1, it means there is a lesion, secondary cancer lesion found in a distant organ, okay, detectable on a site of metastasis, okay, and this means a stage 4 disease, advanced or metastatic disease, okay? So, T, N, and M بنقولهم T and M staging system, very important. Okay. طيب. هلا when we talk about T, N, and M, okay, it means that the carcinoma was invasive. فبالتالي حسب نوع الكارسينوما بنقسمها into in situ carcinoma and invasive carcinoma. Okay, what does it mean in situ carcinoma? احنا حكينا انه when we talk of the structure, we have ducts and lobules, okay, in the mammary gland, and we said that the epithelial cells are surrounded by a basement membrane, and then the whole structures are invading or embedding within the stroma, okay, which contains fat. You see these cells, white cells here? This is fat, okay? وهذا عبارة عن الماتريكس, okay? وهون في عندي الepithelial cells. You see inside here, these are cancer cells, okay? يعني عادة الدكت لازم يكون empty, okay? أو اللوبيول ما لازم يكون في عندي cells inside لأنه إحنا حكينا the structure is only a bilayer of cells, okay? فبالتالي when I see cells inside the duct or the lobule, okay, but they are not invading through the basement membrane. They are abnormal cancer cells, but they are not leaving or they are not migrating or going outside the duct or outside the lobule, okay? We call this in situ carcinoma. Okay, in situ means it stays in its place. Okay, فبالتالي لما أنا بقول ductal carcinoma in situ DCIS, okay, this is cancer. This is not normal tissue. Okay, it's a cancerous disease. It's neoplastic. Okay, these are malignant cells, but they did not have the potential. Okay, they could not, or they still enclosed or included within the structures, the duct or lobule, so they are in situ, they did not invade. فبالتالي, if you look here at the immunohistome, the cells are inside, these are cancerous cells, but they did not go outside through the basement membrane. فهاي بنقولها in situ. Now, if we see these cells, okay, the abnormal cancer cells within the duct, بنقولها ductal carcinoma in situ, okay? If we see these abnormal cells within the lobules, you see this is a lobule, okay? Mammary lobules. If we see them within the lobules, then they are lobular carcinoma in situ, okay? Abnormal cancer cells, they can grow within ducts or they can grow within lobules, as long as they did not break the basement membrane and invade outside the structures, they are called in situ carcinoma. Okay? فهاي بنقولها stage O. Okay, هاي بنقولها stage O. In situ, IS, stage O. How to manage in situ carcinoma is very different from how we treat invasive carcinoma. Okay? What is the percentage of breast cancer patients who have in situ ductal lobular? Maybe 15%, something like that. We encounter in situ carcinomas, okay? More patients have ductal in situ carcinoma than lobular carcinoma, okay, in situ. It has stage O disease, okay? طيب. هلا what if these cells, okay, the abnormal cancer cells, They break the basement membrane and invade through the basement membrane and spread outside the duct or outside the lobule, like here. يعني إحنا عندنا هون بالduct, okay? They were inside, but then they become more invasive and they can just go outside, invade through, and now they spread outside the basement membrane. We see the cells in the stroma and the surrounding tissue. In this case, احنا بنقولها invasive carcinoma, okay? Invasive. And we start to stage from 1 to 4, okay? طيب مين بيعطيني هاي الداتا؟ مين بيقول لي this is an in situ, this is invasive, ductal, lobular? The pathologist, okay? فبالتالي the pathologist, when they check for the core needle biopsy, the tissue biopsy sample, they will in their report tell me whether this is in situ carcinoma or whether this is an invasive carcinoma, okay? فبالتالي invasive carcinoma could be invasive ductal if the cells start in the duct and then invaded through the duct, or invasive lobular, okay? If they break here the basement membrane and leave, okay, to the surrounding tissue outside, okay, بقولها invasive lobular carcinoma. هلا most the cases of breast cancer, I would say like maybe 80%, 70%, mostly, they are invasive ductal carcinoma. Invasive ductal carcinoma is very common, okay? معظم المريضات once diagnosed with breast cancer, they have invasive ductal carcinoma. هذا بنقول له histologic type, histologic, based on histology, okay? فإذا breast cancer, based on histology, okay, it could be in situ carcinoma, whether ductal or lobular, and it could be invasive, and that's the common thing, whether lobular or ductal. فهلا أنا لما بيصير عندي invasive carcinoma, okay, I start to stage from 1 to 4. طبعا هذا الستيجنج أو TNM system هو جاي من الأمريكان Joint Committee on Cancer, okay. فبالتالي when I know T, N, and M, okay, the value of each, I can tell what stage is the disease, okay? هلا each stage 1, 2, 3 is subdivided into a sub-stage, okay? يعني مثلا stage 1 في عندي 1A 1B, stage 2 A B, 3 A B C, okay? فإذا عندي stage 1 2 3 في عندي stage 4. هلا if I did my check ولقيت إنه المريضة the tumor size below 2 centimeters, I checked like 10 lymph nodes and they were all negative. They did not contain cancer cells. I did my CTs and there was no distant metastasis. Then it is T1NOMO disease. This correlates with the stage 1A. Okay. طيب إذا إجيت لقيت إنه المريضة عندها التيومر سايز for example كان 6 centimeters وكان عندها 2 positive lymph nodes with cancer involvement out of 10 فبتاخد value in 1 M0 فهاي بتصير stage 3A. هلا stage 4 any T any N as long as I have metastasis the patient is directly a stage 4 or advanced disease. Okay. هلا generally speaking أنا ما بدي أكو تحفظوا هاي الأشياء لكن generally speaking when we talk of stage 1 disease, okay, لما أنا بحكي stage 1 breast cancer it means an invasive carcinoma. It's not in situ, okay? Stage 1, stage 2, 3, and 4, this is an invasive carcinoma. Stage 1 usually smaller tumors and usually no lymph node involvement عادة. Okay, أو بتكون minimal involvement. Okay, لما بحكي stage 2 disease, usually the cancer cells become أو الtumor mass بتكون larger. I start to see in stage 2, I start to see lymph node involvement. Okay. بstage 3 disease هذا بنقول له stage 3 بنقول له locally it's still local لأنه ما في distant metastasis. It's stage 3. The disease, the cancer cells are still in the breast. It's local, but it is advanced. It's locally advanced. Why? Because usually the tumor size is larger and there is extensive lymph node involvement, okay? And you can see in 2 and 3, there is many lymph nodes are usually involved, okay? فإذا أنا بدي أرجع على الستaging, stage 1 and stage 2 بشكل عام إحنا بنقولهم local disease, early local disease, okay? Stage 3, advanced local disease. Stage 4 is a metastatic or advanced disease, okay? To treat patient or to come with a pharmaceutical care plan to a patient with breast cancer, we must know the TNM stage. We must know that this is an in situ or invasive. If invasive, what stage? Okay, metastatic, local, locally advanced. We need to know all these information along with the molecular subtype اللي حكينا عنه last time. Okay. هلا احنا لما بنحكي يعني for women in the public or community, why we said that screening, early screening detection is important. Why? Because as long as we move through the stages, okay, from 1 to 4 about invasive disease here, because stage O means in situ disease. As we go from 1 to 4, the cure rate is decreasing, the survival rate is decreasing. هلا أنا لما بحكي إنه patients who are diagnosed as stage 1 disease, okay, it's mostly a small tumor and in most cases it's lymph node negative disease. فبالتالي الكيور rate بيكون عالي كتير. فلما أنا بحكي survival rate أو the cure rate is high, definitely that cure rate will decline لما بيصير في عندي lymph node involvement أو larger tumors. And actually if we talk about stage 4 disease, metastatic disease, يعني إحنا بنعتبر إنه هون the goal is not to cure, هون palliative, okay? يعني you cannot really cure tumors that have spread through body organs. ما بنعتبرها curative treatment. إحنا بنعتبرها palliative treatment. ورح نحكي شو يعني palliative chemotherapy. Okay? early detection, the screening مهم لأنه if you catch the disease early, the chances for cure and survival is much higher than presenting with more advanced disease. Okay? للأسف on the nation level يعني National Cancer Registry آخر update له, we still have a good proportion of women in the community. When they present, they usually present at stage 3 disease. في تقريبا 15% of patients, they present with metastatic disease, which means advanced disease, okay? برغم programs and national awareness programs about the importance to do early screening and detection of breast cancer, لسه في عنا حالات كتيرة عم تيجي for women who come at more advanced stages of the disease. وبالتالي this will jeopardize definitely يعني the chances or يعني the survival and cure rate بيكون أقل عند هدول المريضات. Okay? فبstage 1, 2 and 3, okay, our goal is to cure, or definitely stage O, but this is not invasive, okay, this is in situ disease. But with stage 1, 2 and 3, our goal is to cure, but the cure rate will decline as the patient advances. And the stage 4 is metastatic disease, and this is not actually, we will not be able to cure actually. Okay, بنعتبره أكثر palliative management. هلا البروجنوستيك فاكتورز بالبريست كانسر بمعظم السوليد كانسرز كتير مهمة. يعني if we have a patient with breast cancer that is confirmed with pathologic exams, okay, with biopsy, what are her chances for relapse, recurrence, responding to chemotherapy, for example, okay, for cure? في أشياء بنقولها prognostics وهي كتير مهمة بالبريست كانسر. Okay, age is a very important prognostic. هلا بشكل عام, okay, the younger the age of the patient at presentation, the worse the prognosis. يعني بشكل عام لما إحنا بنحكي breast cancer, it's the median age in 60s. طبعاً هذا حسب US statistics. I have seen patients who come at 20s, at 30s with breast cancer. Usually young age يعني احنا بنعتبره below 35 or 40 years old بعتبره أنا early disease, okay? In young age. Usually the tumor type is more aggressive. يعني معظم المرضى اللي بيجوا with breast cancer بالyoung age بيكون basal-like أو triple negative. And these tumors are aggressive. Most patients who come with breast cancer in 50s or 60s in post-menopause معظمهم بيكونوا luminal type or hormone dependent. Okay, their prognosis is better. فبالتالي age is very important determinant. The tumor size with lymph node involvement very strong and very important. كل ما زاد التيومر size وكل ما كان في عندي lymph node involvement وزاد ال N value, okay, the prognosis is definitely worse and the chances for relapse or recurrence بتكون أعلى. Okay. هلا the grade of disease وإحنا حكينا عن the grade قبل هيك. The grade tells you about how aggressive and the proliferation rate of carcinoma. Okay. بالبريست كانسر أو بالsolid cancer عندنا في 3 grades. يعني في عندنا grade 1 disease, grade 2 disease and grade 3 disease. Low grade means grade 1 disease. لما بيكون عندي low grade أو grade 1 disease, it means that these cancer cells, okay, they proliferate, but they are still differentiating, okay? يعني the proliferation rate ما بيكون كتير عالي. لما أنا بحكي high grade disease or grade 3 disease, okay, it means that these are basically proliferating cancer cells, non-differentiating. وبالتالي بعتبره more aggressive disease. فكل ما زاد الجريد okay كل ما كان prognosis worse and the tumor is more aggressive, okay, and more proliferating. في شيء كمان مهم كتير بنقول له lymphovascular invasion, okay. لما الباثولوجيست بيعمل تشيك على البايبسي, okay, they will check the blood vessels in the tissue. If they see inside the blood vessel, if they see cancer cells, okay, within or inside the blood vessel, it means there is lymphovascular invasion. The cancer cells invaded the blood vessels or the lymphatic, okay. فبنقول إنه in this case lymphovascular invasion is identified or it is present. This implies also worse prognosis مع إنه lymphovascular invasion ما بنعتبره very strong factor, but it's still considered a bad or advanced prognostic factor. ليه؟ لأنه هذا معناه إنه the potential of these cells to invade is high. بالتالي their metastatic potential could be high. فإذا the presence of lymphovascular invasion is bad. طيب, if we check the blood vessels and we did not see any cancer cells inside the blood vessels or lymphatics, in this case, بنقول إنه lymphovascular invasion was absent or unidentified. We could not see it عند هاي المريض. فالlymphovascular invasion شغلة we look at it لما بنعمل assessment. The final thing and very important thing is receptors. إحنا قلنا إنه we look at 3 different receptors when you talk of breast cancer. هدول كتير مهمين. 2 hormonal receptors, estrogen receptor and progesterone receptor, and 1 tyrosine kinase receptor, which is HER2. Okay. Generally speaking, if the patient is positive, if the cancer cell express progesterone receptor and or estrogen receptor, any of the hormone receptors, we consider the prognosis is good. Okay. هلا, if the patient has negative expression, the cancer cell does not express any of these 2, نعتبره hormone receptor negative disease, and this is considered a bad thing, okay, or an adverse prognostic thing. طيب, if the patient has positive expression of HER2, this is a bad thing, okay? And a positive HER2 receptor is an adverse prognostic factor. while positive expression of hormone receptors is a good prognostic factor. Why? لأن الإكسبريشن of receptors بيرجع على الموليكولار subtype، وإحنا قلنا لما شرحنا المحاضرة الماضية أنه الluminal type, luminal A or B, they have better prognosis compared to HER2 positive, which is ER negative disease, PR negative, but HER2 positive disease, and compared to the triple negative, the basal-like, which is negative for ER, PR, and HER2. فبالتالي وجود الهرمone receptors positive expression is good for the prognosis. The absence of hormone receptors is bad, and the presence of HER2 positive disease is also something bad. Okay? فهاي كلها احنا بنقولها prognostic factors. We set it ahead in mind. Why? لأنه هذا ممكن أحيانا يعني it guide me through the treatment or through the number of cycles of chemotherapy, or if I need to complete my anthracycline-based protocol and then give a taxane لأنه عندي lymph node negative positive disease مثلا. Okay, فبالتالي هاي الأشياء prognostics we keep it in mind because it's important for treatment. كل ما جمعنا more adverse factors كل ما كان risk of recurrence or relapse عند هاي المريضة يعني higher أو becomes a more serious thing. We have to take it into consideration. طيب هلا إحنا حكينا إنه to treat the patient we need to know, confirm it's breast cancer. We need to know the molecular subtype. We need to know the histology, in situ or invasive, and we need to know the stage. Okay? To be honest, بالhospital practice يعني being pharmacists هاي المعلومات كلها you will come to know it will come to you. Okay? يعني you don't really contribute in any of this. بس لازم تكونوا عارفين كيف بتوصل هاي المعلومات. Okay? If you know as a pharmacist, if you know that it is ductal or lobular carcinoma in situ, you should come with a treatment plan, or you should be able to propose or suggest a treatment plan. طيب إذا كانت الكيس ductal carcinoma in situ, by definition إحنا قلنا ductal carcinoma in situ means that the abnormal cancer cells exist within the duct and they did not spread. They did not even spread in the mammary tissue. ما طلعوا من الduct أو ما طلعوا من اللوبيولز. طيب what should we do? يعني بهاي الحالة what is the best treatment to do? We have to do excision. شو يعني? We remove that part of the breast that contains the ductal carcinoma in situ. طيب can we do irradiation after we do the excision? Yes, sometimes we do. فهون احنا بنعمل external beam local irradiation. طيب احنا هلا we removed with surgery, we did excision and we did irradiation to the involved breast. طبعا البريست cancer, just an information. It could be unilateral, يعني الماس الابنورماليتي بتكون in one breast only, left maybe right. وأحيانا في مريضات بيجوا بيكون عندهم bilateral disease, which means that there are masses, there is cancer in both the left and the right breast. Okay? طيب if I come to a patient عملنا لها mammography لقينا عندها mass in the right breast. انعمل biopsy طلع عندها ductal carcinoma in situ, single mass in the right breast only. هاي المريضة simply we do lumpectomy, we remove that part of the breast, okay, that contains that mass or that cancer cell. We can sometimes irradiate, and we do not with carcinoma in situ, we do not give systemic cytotoxic chemotherapy. Okay, ليه؟ لأنه الcancer cells did not invade through the duct or the lobule. بالتالي the potential that these cells had spread outside the chest, for example, or the breast is almost null. فما في داعي أعرض المريضة للtoxicity of the systemic chemotherapy. Cytotoxic therapy means chemotherapy. يعني الكيمو الهدف منها لما بعطيها أنا هون to kill the cancer cell. اوكي. فاذا بدك الكارسينوما in situ, remove the mass. Sometimes you might need to irradiate. Okay. No role, no place for chemotherapy, systemic chemotherapy. However, إذا المريضة عندها luminal disease أو hormone dependent disease, okay, she is a candidate to receive endocrine treatment, endocrine drugs. ليش بعطيها أنا بعد ما أعمل السيرجري وبعد ما أعمل الراديشن بعطيها أنا الهرمونال تريتمنت أو الإندوكرين تريتمنت to prevent ductal carcinoma in situ in a new disease or a new onset. يعني هون بعطيها preventive therapy. أوكي. فبعطيها أنا الهرمونال دراج إذا كانت المريضة hormone dependent disease لأنه هي targeted therapy. أوكي. طيب إذا ما كانت هرمونال يعني إذا ما كانت luminal أو hormone dependent, that's it. That's all we go with. Surgery, radiation. Maybe yes, no. يعني radiation ممكن ممكن لا. فالcure rate with ductal carcinoma in situ is very high. Okay. To prevent relapses in the hormone dependent disease, we give hormonal treatment. ورح نحكي about tamoxifen والaromatase inhibitors in big details later on. Okay. طيب sometimes إذا كان عندي several masses of ductal carcinoma in situ, يعني لقيت مثلا في 4 or 5 different masses أو المريضة كانت BRCA positive disease, we do mastectomy بهاي الحالة. Okay, we do mastectomy. رح نحكي about the types of surgery and mastectomy. Okay. هلا lobular carcinoma in situ يعني مشكلة lobular carcinoma it's not very detectable بالماموجرافي. يعني أحياناً you have to keep in mind إنه هاي السكرينينج tools إلها limitations. Okay. lobular carcinoma in situ مش يعني ممكن أعمل ماموجرافي بيطلع عندي نيجاتيف ما في مشكلة يعني ما في ماس ما في calcifications ما في abnormality. ممكن يكون في lobular carcinoma in situ but failed to be detected on mammography. عشان هيك معظم حالات ال LCIS هي accidental actually. Okay, accidental. Sensitivity of mammography is not that good. Okay. وبالclinical trials لقيوا إنه يعني radiation or chemotherapy, systemic chemotherapy or even radiation is not good enough for LCIS. Okay. Sometimes you can make surgery or excision. Okay. إذا كانت hormone dependent الكارسينوما cells أو إذا كانت positive for estrogen or progesterone receptor كمان ممكن نعطي إحنا hormonal treatment or endocrine therapy based طبعاً على الكيس تبعت المريضة. فالlobular carcinoma in situ, we don't know much about it because I think many cases go undetectable because the detection mammography is not that good. Okay, it's very incidental in treatment or even in diagnosis. Okay. It's not as common as ductal carcinoma in situ, more common. فهذا بالنسبة لل in situ carcinoma. If I have a DCIS disease, ductal carcinoma in situ, if I remove the lesion, if I do radiation, give tamoxifen maybe, or other drugs, if the carcinoma is hormone dependent, usually have a very, very high cure rate. يعني the chances of relapse أو recurrence بتكون very minimal. Okay. Keep in mind إحنا عم نحكي عن stage O disease. Okay, this is non-invasive disease. طيب. هلا we will move to the invasive disease. فبالتالي إحنا عم نحكي عن stages from 1 to 4. الكتاب your textbook is dividing the treatment based on this stage. Okay, فبالتالي بالكتاب أول paragraph بالtreatment أو أول part بالtreatment is about the local early disease. فلما أنا بقول لكم إنه هاي المريضة breast cancer case of local early disease, it means she is either stage 1 or 2. الستيج الثالث or stage 3 بنقول له locally advanced وهذا مفصول يعني separated the treatment from the early local disease. والجزء الأخير بالمانجمنت هو management of metastatic breast cancer. Okay, metastatic stage 4 disease. فالكتاب مقسم management of invasive breast cancer based into the stage into 3 different parts. Okay, فناو I will start with the early local disease اللي هو stage 1 or 2 على ال TNM staging. Okay, stage 1 or 2. Any patient, okay, بنعملها biopsy تيجي بtumor mass that is invasive disease, whether invasive ductal or lobular, okay? Regardless of the tumor size, okay, below 2, above 2, any patient, breast cancer, invasive, لازم تعمل surgery. فالsurgery is a very important modality in stage 1, 2, and 3, okay? فsurgery is a cornerstone. لازم تعمل surgery. We have to remove that mass, okay? طيب نفترض المريضة اجت stage 1 أو stage 2 ready resectable tumor. شو يعني كلمة resectable؟ هاي keep it in your mind لأنه رح نحكيها كتير بالsolid cancer. Sometimes when the patient presents, the tumor mass can be operated directly. يعني the surgeon can remove the mass directly. فبالتالي size is resectable, operable tumor. Sometimes the tumor can be removed with surgery, but not the way it presents. يعني بيكون a little bit big tumor, okay? Operable still, we can do operation, surgery, and remove, but we have to shrink the tumor first. We have to make its size a little bit smaller, okay? فهو potentially resectable, but not directly resectable, okay? هلا بشكل عام احنا لما حكينا about TNM staging, stage 1 and 2, حكينا انه يعني we don't have very big tumors. حكينا انه big tumors اللي هي ممكن تكون T2, T3, extensive lymph node involvement, usually we see this in stage 3 disease, the locally advanced. But by definition, in most cases, patients with a stage 1 and 2 breast cancer, the tumor is resectable, operable, okay? هلا لو the tumor is not directly resectable, okay, we can make it resectable with neoadjuvant chemotherapy ورح نحكي عنه. خلينا احنا نحكي عن مريضة بstage 1 or 2 with resectable tumor, okay? Directly resectable tumor, operable tumor. أول شيء بينعمل بالمانجمنت هو السيرجري. فهاي المريضة once everything بالdiagnostics is done, أول شيء بتعمله booking, بتروح على breast surgeon. The breast surgeon بيعملها surgery. طيب شو أنواع السيرجري to remove the breast tissue or mass? We have many, okay? ففي إشي بنقول له إحنا lumpectomy, wide excision or quadrantectomy بما معنى. In this case, we are either removing just the tumor or the tumor and some of the surrounding tissue. لكن بالbreast conserving surgery, ليش اسمها conserving? We are not removing the whole breast tissue. We are still keeping it, okay? فبالbreast conserving surgery, okay, we are removing the tumor وأحياناً we remove also part of the lymph node اللي هو الأكسلري رح نحكي عنها هلا. لكن we are not removing the whole breast mass or breast tissue. Okay, we are still keeping the breast tissue. فهاي بنقولها breast conserving surgery. فلما أنا أقول لكم إنه هاي المريضة لكم Mrs. X عمرها 60 years وصار معها stage 2 disease عملت breast conserving surgery. What should you understand from that? إنه هاي المريضة part of her breast tissue that contained the tumor has been removed, but not the whole breast tissue. Okay, not the whole breast tissue. Lumpectomy or breast conserving, you can remove only a very small part. You can remove the tumor and some of the surrounding breast tissue. إلها أنواع. Okay. طيب. The other kind of surgery is called mastectomy. But when I tell you that the patient has mastectomy, لما أقول لكم إنه المريضة عملت mastectomy, okay, بغض النظر radical modifiable. If I tell you the surgery was mastectomy, it means the surgeon removed the whole breast mass, the whole breast tissue, the whole breast has been removed. Okay. هلا The consideration to do mastectomy or breast conserving had a decision, okay. It goes back to the breast surgeon discussing with the patient. أحيانا بيعتمد على التيومر type، أحيانا بيعتمد على السايز، عدد الابنورمال ماسز مثلا، يعني في كتير considerations، فهذا decision بيرجع للسيرجن، اوكي. فإذا لما احنا بنحكي mastectomy، اوكي، removal of the whole breast tissue. هلا الموديفايد راديكال ماستكتومي، اوكي، السيرجن هون شو بيعمل؟ he or she removes the whole breast tissue, okay, plus some of the skeletal muscle below, plus the axillary lymph node. عشان هيك احنا نقول له radical extreme، okay. فهون احنا قاعدين basically removing almost everything، okay. امتى انا بعمل modified radical؟ if I have doubts انه actually the lymph nodes are involved، عندي lymph node يعني positive او lymph node involvement، okay. if I am pretty sure انه في high lymph node involvement، okay, you also remove lymph node base اللي هو شو axillary lymph node هون، اوكي. عم نحكي عن الاكزيلاري lymph node، وبيضل السيرجن يشيل التشو لحتى يوصل على المصل، على الترابيزيوس تحت، وحتى بيشيل منها جزء. فعشان هيك احنا بنقول له radical mastectomy. all the breast tissue is removed، كل بريست انشال مع الاكزيلاري lymph node، اوكي. هلا ال decision to do mastectomy or to do breast conserving بيرجع للسيرجن وبده consenting من المريضة، اوكي. هلا بشكل عام البريست conserving therapy or surgery، اوكي، بتنعمل للمريضات اللي بيكونوا stage 1 or 2 very small tumors، وعلى الأغلب يعني we rule out or we don't have big doubts إنه في lymph node involvement، okay. If you compare the risk of recurrence or relapse، okay, between breast conserving surgery and mastectomy، يعني إذا إجيت أنا للبيشنت وخيرتها، قلت لها إحنا ممكن نعمل mastectomy and we remove the whole breast tissue، or we can just remove the tumor and surrounding some of the surrounding tissue. لكن الريسك مع البريست conserving surgery of relapse هو أعلى شوي من الماستكتومي. يعني إذا إحنا بنقارن إنه the relapse the recurrence risk، بما إنه التشو اللي صار فيه النيوبلاستيك transformation still exists، الريلابس بيكون أعلى شوي، okay. فهو مش huge risk but compared to mastectomy it's a little bit higher. في كتير patients believe it or not، okay, they will choose to go to mastectomy for maybe a 1% chance أو 2% chance. يعني المريضة بتقول لك لا اعملوا لي mastectomy، remove the whole breast tissue، ما عندي مشكلة، و I will not jeopardize take the risk إنه ممكن في 1% زيادة أو 2% زيادة that the disease will come again. I did a lot of research بالمستشفى المؤسس، وحوالي يعني I would say ممكن 80 ل 90% من مريضات البريست كانسر they do mastectomy. حتى بالearly stages they choose to go to mastectomy because they are very much concerned about relapse and recurrence. فإذا أول ستيب بنعملها هي السيرجري، mastectomy or lumpectomy بغض النظر. طيب if we go to breast conserving therapy أو عملنا lumpectomy وما عملنا البريست تيشو كامل، البريست conserving therapy it is a must، it's not optional هون. The patient should do radiation and should take or يعني administer systemic chemotherapy if the tumor size was more than 1 centimeter in dimension أو إذا كان عندها lymph node positive disease رح نحكي عنها، أوكي. فبالتالي بالبريست conserving therapy it's not optional، والبيشنت لازم تكون aware إنه إذا إحنا عملنا breast conserving therapy if we did lumpectomy only part of the breast containing the tumor was removed, you will have many sessions, okay, of local chest radiation. فهون الradiation is to the chest it's local. والهدف منها شو؟ إذا في any small micrometastatic disease, because keep in mind this is invasive carcinoma here, okay? يعني هي طلعت already من اللوبيول أو من الدكت. فإذا في any potential of micrometastatic disease in the chest, the radiotherapy will take care of it. فهاي المريضة بتكون عارفة إنه بعد السيرجري رح يكون في extensive maybe 5-week course, sometimes even more, many radiologic sessions في radiation في chest radiation رح تتعرض لها. وكتير patients كمان بيكونوا eligible to systemic chemotherapy بالbreast conserving. they should be prepared to that. Okay? فإذا إحنا مثل ما حكيت بالbreast conserving surgery we are just doing lumpectomy. Okay, we're removing the tumor. ودائما لما بنقيم the tumor we always remove part of the adjacent tissue. Okay, والدكتور بيبعت هذا الجزء بنقول له surgical margins. Okay, رح تقروه بالكتاب. والsurgical margins هاي بتنبعت على الباثولوجي department والباثولوجيست بيشوف هل هاي المارجنز فيها cancer cells or not. فclean surgical margins is something good. لكن إذا لقينا إنه surgical margins contain cancer cells, this is something bad. Okay? فبالbreast conserving surgery, what the doctor does usually, surgeon, they remove the tumor with the margins, and they also remove some lymph nodes axillary for check and investigation. هل فيها cancer cells أو لا؟ Okay? فهاي إحنا بنقولها breast conserving. After that, patient will be subject to chemotherapy, radiotherapy. Radiotherapy is a must, okay? بالbreast conserving surgery, she must get radiotherapy. في شغلة بس حابة أحكي لكم عنها لأنه I think it will come to you through the book when you read the book. هلا في إشي يعني هلا إحنا في عنا small tumor، أوكي؟ طيب هل في lymph node involvement أو لا؟ إذا إحنا عملنا يعني lymph node dissection, we will check the lymph node. لكن before going to the surgery, do we really need to do that? لأنه هون بضل يعني keep in mind there will be a scar here وفي عنا complications كتير. يعني حتى lymph node drainage هون ممكن أحيانا بعض المريضات يصير معهم complications. طيب يعني how should we know without dissecting أو without ما نعمل axillary lymph node dissection إذا في lymph node involvement أو لا؟ في تكنيك أو في procedure بيقولوا لها sentinel lymph node check أو exam. الsentinel lymph node هي يعني the very first lymph node to receive drainage from the tumor. أوكي يعني شو أول lymph node surrounding the tumor؟ هاي بنقولها sentinel lymph node. What they do now in sentinel lymph node checkup, they give a dye. أوكي بينعطى dye للأريا اللي فيها التيومر. والداي will go بيصير drainage بيروح على lymph nodes surrounding the tumor. Okay. هلا هاي البروسيجر رح it will give me an idea. Okay. إنه إذا sentinel lymph node هاي فيها تيومر واصلها تيومر معناها ممكن يكون واصل على اللي وراها، ممكن يكون عندي lymph node positive disease and I might need to do this axillary clearance thing. لكن إذا أول يعني very close adjacent lymph nodes were free ما كان فيهم involvement ما في cancer cells, what's the chance إنه the other axillary or other locoregional lymph nodes, the lymph nodes in the chest region to receive أو يعني إن يكون واصل عليهم the tumor the breast cancer يعني هاي questionable. يعني هي نوع من إنه can we tell if there is lymph node involvement or not without the need to do axillary lymph node dissection? هلا في بالكتاب عندكم كاتبين إنه it can give you a hint but sometimes it is not enough. Okay. فيعني lymph node negative disease is something يعني إحنا بنعتبره good prognostics that the tumor cells did not reach the lymphatic system or lymph nodes. As long as we can make strong decisions about that lymph node negative disease, okay? يعني أنا مثلاً أعتبر إنه المريضة lymph node negative while I did not sentinel lymph node check أو ما فحصت عدد كافي من الليمف نودز بالأكسيلري بيزن مثلا، يعني that's something questionable. Okay. فالsentinel lymph node هلا we can check it whether it contains or includes cancer cells or not. يعني هاي ما بتحتاج إنه أنا أعمل surgery. I only inject a dye, okay, and look at the reaction. إذا المريضة عملت mastectomy, okay, if the decision was to go to mastectomy, مش دائما المريضة اللي بتعمل mastectomy بتكون eligible to chest radiation. إحنا قلنا بالbreast conserving any patient that will go to breast conserving surgery must do chest irradiation. Okay. طيب مين المريضات اللي إذا عملوا mastectomy, which means we remove the whole breast tissue, they are still eligible, okay, to do radiation. هون في عليها issues بس ال NCCN guidelines أعطتنا hints، يعني مين المريضة اللي هي عاملة mastectomy و still she needs to do radiation in stage 1 or 2 disease. إحنا عم نحكي stage 1 and 2 ليه؟ لأنه بstage 3 disease اللي هو locally advanced all patients after surgery they must do radiation. Why? Because the tumor is big, lymph node involvement is huge. فإحنا هون عم نحكي بstage 1 or 2 the early local disease. Which cancer patient, breast cancer patient who do mastectomy is eligible to chest irradiation. فهدول مكتوبين عندكم بالكتاب تقروهم carefully. Okay, مين المريضة stage 1 or 2 that she is eligible to post mastectomy irradiation. Okay, إذا ما فهمتوا إشي من اللي مكتوب بالكتاب let me know. فمش أي مريضة بتعمل mastectomy بstage 1 or 2 بتكون eligible أو لازم أعطيها chest radiation. يعني ما بيصير مريضة مش eligible أوكي أعطيها chest irradiation أوكي 5 أسابيع وممكن أعملها toxicity وأعملها secondary malignancies later on وهي مش eligible. فلازم أعرف مين المريضة eligible أوكي stage 1 and 2 and post mastectomy for irradiation. أوكي فإذا surgery and radiotherapy هدول الاثنين هدول local treatment. لما بنحكي عن البريست كانسر أوكي هدول local treatment. يعني إذا في عندي cancer cells micrometastatic to lung to liver أوكي أو مثلا viscerally invaded, the surgery, the radiotherapy will not catch, will not kill or destroy. Okay, but the only way to control micrometastatic disease is to give systemic cytotoxic therapy, systemic chemotherapy. هلا مين المريضة اللي لازم تاخذ systemic chemotherapy? Generally speaking, all breast cancer patients with lymph node positive disease or all breast cancer patients with T tumor size more than 1 centimeter لازم ياخدوا systemic chemotherapy. It's a must. Okay? لازم ياخدوا systemic chemotherapy. هلا systemic chemotherapy based on the sequence of administration ايمتى بعطيها؟ بالنسبة للlocal therapy بنقسمها ل 2 big types, adjuvant and neoadjuvant. فلما أنا بقول لكم إنه المريضة adjuvant chemotherapy معناها رح تاخد الكيموثيرابي after surgery, okay, after the local treatment, okay. فهي بتيجي بعد السيرجري. فبقول لك systemic adjuvant chemotherapy the patient اللي انتم بتفهموه هون إنه البيشنت رح تاخد الكيمو بعد السيرجري, okay. طيب if I tell you this is a neoadjuvant chemotherapy, neoadjuvant it means before surgery, okay. طيب احنا امتى بنعطي الكيموثيرابي before surgery؟ مثل ما حكيت إذا كان التيومر size big، يعني معظم مريضات stage 3 disease، okay. حكينا بstage 3 there is lymph node involvement, the tumors are usually big. And so they are not operable, they are not resectable directly, but they could be resected when we downsize or downstage. يعني أنا إذا إجتني مريضة بستيج 3 تيومر، أنا شفت مريضات بالمؤسس تخيلوا التي يعني حجم التيومر وصل 12 و13 سنتيمتر. huge tumors, big huge tumors. التيومر بهذا الحجم ما بيقدر السيرجن يعمل له ريسكشن. فهاي المريضة بتيجي مثلا بستيج 3 disease. It can be removed but not on its current stage or presentation. We have to shrink the tumor يعني نصغره so it becomes potentially resectable. نقدر نقيمه. فبتاخد هاي المريضة أول شيء بتاخده هو chemotherapy. The chemotherapy will shrink, downsize or downstage. وبتاخد الكيمو هون فترة يعني short، شهرين مثلا، أوكي؟ مش بدي أعطيها كيموثيرابي كأني عم بعالجها adjuvant. لا، الهدف بالنيو adjuvant systemic chemotherapy لهاي المريضة بالستيج 3 is to induce resectability, to downstage, make the tumor size smaller, and so the surgeon can remove it with surgery or operation. A short course of chemotherapy, neoadjuvant, and reassess the tumor. معظم المريضات بعد شهرين من الكيموثيرابي their tumors become resectable. They shrink, the size is reduced, and now the surgeon can remove it. فهاي بنقولها neoadjuvant chemotherapy. وهاي very common approach بstage 3 patients. Why? لأنه هدول المريضات عادة بيجوا the tumor size is usually big, okay, and not operable. هلا كل مريضات stage 1 and 2 okay اللي هم عملوا surgery وكان التيومر سايز عندهم أكثر من 1 سنتيمتر. أنا بصراحة لما اشتغلت هون أو بالخدمات الطبية الملكية كان الافريج سايز، يعني بنحكي عن الافريج المين، يعني ممكن إذا بدي أعمل بولينج للداتا ممكن أكثر من 1000 مريضة بالدراستين اللي عملتهم. الافريج كان يمكن 3.5، يعني كان T2 أساساً. اوكي يعني very unlikely، ما بتذكر مرق علي مريضة كان التيومر تبعها تحت 2.5. اوكي فمعظم المريضات بيجوا بتيومرز above 2 or 1.7 something like that. فهم eligible لازم ياخذوا كيموثيرابي بعد السيرجري. اوكي فهاي الكيموثيرابي اللي بدها تنعطى بعد السيرجري بنقولها adjuvant chemotherapy. Why we give chemotherapy after surgery, even to early local disease? To control micrometastasis, secure the case, the condition, reduce relapses or recurrence disease. Okay? فالسيستميك chemotherapy كتير مهمة بالمريضات اللي هم عندهم early disease أو stage 1 or 2 early local disease. هلا في عندكم بالكتاب في كاتبين about يعني ال tools to calculate the risk of recurrence. A very important tool بنقولها Oncotype DX. Okay. هاي عبارة عن analysis which is based on PCR. Okay. It will يعني detect أو count أو calculate ال risk of recurrence لأي مريضات هاي مش universal tool. You can use Oncotype DX to assess recurrence risk in patients with ER positive, node negative invasive breast cancer. يعني المريضة اللي عندها hormone dependent ER positive breast cancer and negative lymph nodes، ما في lymph node involvement, it's invasive، يعني هاي ما بتمشي الأونكوتايب DX. ما بقدر أعملها أحسب recurrence score لمريضة جاية ductal carcinoma in situ. It does not work. أو أحسب recurrence score لمريضة عندها lymph node positive disease اللي تبعها 1 or 2. غلط. أو أحسبها لمريضة HER2 positive ER negative. غلط. أوكي فهاي very يعني very customized. اوكي اللي بيصير بياخذوا blood sample من المريضة و tissue sample. اوكي and they run the sample okay into this Oncotype DX. okay الOncotype DX النتيجة بالنهاية هي رح تكون سكور، رقم. أوكي، هلأ حسب الرقم المريضة يا إما بتكون high risk of recurrence أو low risk of recurrence. أوكي، اللي high risk of recurrence لازم تاخد كيموثيرابي، لازم تاخد كيموثيرابي. أوكي، يعني الهرمون تريتمنت أو الاندوكرين تريتمنت alone is not enough. فبالكتاب مكتوب عندكم السكورز، الرينج تبعها ايمتى بتكون المريضة low recurrence risk and endocrine therapy might be enough without chemotherapy، وإمتى المريضة بتكون high recurrence risk and must receive adjuvant chemotherapy before endocrine therapy، وفي area الانترميديت بالنص اللي هي مش كتير مبينة. أوكي، فاقرأوا السكورز تبعون الأونكوتايب دي إكس لأنها كتير مهمة. أوكي، وهي مثل ما حكيت very special and very customized، مش لكل مريضات البريست كانسر. هلا في other tools، يعني في الماما برنت، في غيرها. اوكي، بس الأونكوتايب هي للهرمون ديبندنت ER positive lymph node negative invasive disease. مش أي مريضة هي candidate اوكي إنه إحنا نعملها الأونكوتايب دي إكس analysis. اوكي، طيب خليني أوقف هون. بدي أنزل الحضور والغياب لو سمحتوا، ما حدا يطلع. يا ريت تاخذوا موضوع الحضور والغياب يعني سيريسلي. أنا كتير نبهت بالمحاضرات. أوكي، يعني أنا بتوقع إنه it is not something big to access your lecture أو class. أوكي، فلو سمحتوا يعني موضوع الحضور والغياب is something serious. I do it regularly and I will keep doing it. يعني رح أضل أخذ حضور وغياب، فلو سمحتوا اللي ما عنده ظروف قهرية ما في داعي يغيب. أوكي، let's assume إنه أنت عندك حالة طارئة أو emergency. Get into your class. You can maybe later on excuse yourself إذا في يعني big issue that you cannot attend your lecture. But just skipping your lectures and not attending for no valid reason, you never guess what can happen next day. يمكن تضطر تغيب. save this، يعني وفر غياباتك يعني لما تحتاجها فعلا. اوكي، لكن just consuming all your absences واحنا لسه يدوم امتحانين مد قبل يومين is not really a good idea. ليش اغيب اذا انا بقدر احضر؟ وانتوا وضعكم بصراحه complicated، وانا I explained this to you before. يعني هذا الكورس بينطرح تقريبا مره واحده بالاكاديميك يير، مرتبط بكورسات تانية. Why would you put yourself jeopardize your status in more than one course؟ يعني لأنه أنا I'm just not attending and I'm skipping my lectures. فلو سمحتوا موضوع الحضور والغياب يعني مهم. I am recording it regularly. كل طالب يشيك ليعرف قديش عنده غيابات. أوكي، يا ريت كل طالب يحضر من الأكاونت تبعه لو سمحتوا، لأنه لهلا عم يبعتوا لي طلاب أنا حاضر وبيكون داخل من أكاونت مش الأكاونت تبع الإي-ليرنينج تبع الطالب. فبليز make sure إنه أنت داخل من الأكاونت تبعك على محاضرتك بوقت المحاضرة. أوكي، يعني things are simple. يعني do not embarrass yourself, do not jeopardize your status. إنه أنت يعني drop the course أو issues with registration, missing exams، يعني it's complicated. فسيمبلي أنا بحضر محاضرتي، هم يعني يومين بالأسبوع، يعني مش big deal. فلو سمحتوا الحضور والغياب I will keep recording it. يعني حتى بعد المد I will keep recording it. رح أضل أخذ حضور وغياب. ف don't take risks, don't make assumptions. Please don't make assumptions. يعني أحياناً الطلاب they make their own assumptions. They make assumptions إنه خلص امتحنا مد الدكتورة أكيد ما رح تفصل حدا وكذا. Do not make your own assumptions. Okay? I will keep recording it. أنا رح أضلني أخذ حضور وغياب لأنه هيك regulations. أوكي؟ regulations التعليم العالي، تسجيل الحضور والغياب بشكل دوري ومنتظم، مطلوب منك أنت كطالب تحضر. فلو سمحتوا take it seriously. أنا مش رح أكون impressed or happy if any of you is dropped because of attendance. فلو سمحتوا احرصوا على موضوع الحضور والغياب. اوكي. هلا بالنسبة لامتحان المات I think the grades were good، يعني العلامات منيحة. الافرج is good I think بال 35 يمكن شيء مثل إذا ماني غلطانة، يعني لكل الشعب طبعا لأنه هو pooled. ف I think your grades are good. هلا في طلاب بعثوا لي قالوا لي بالنسبة لوقت الامتحان، يعني بصراحة أنا والدكتور بلال we thought a lot about it and we think that 1 hour would be fair enough. يعني ما أظن إنه that was a big concern، لكن بشكل عام يعني my advice to you، لأنه امتحاناتكم هي one way أو sequential، يعني السؤال اللي بتدقر عنده، يعني مثلا أنا إجيت على سؤال وتلخبطت بالإجابات مشان don't give it a lot of time، لأنه هذا رح يستهلك من وقتك لسؤال ممكن يكون وراه أنت you can answer it in no time. يعني always make your own calculations. أنا عندي ساعة و40 سؤال، في أسئلة ما بتاخد maybe 10 seconds to answer. يعني أنا لما بجيب لكم سؤال بقول لكم شو ال TKI of choice بال T315I mutation، هذا المفروض يعني سؤال مثل هيك it should not take maybe 10 seconds to answer it. فإحنا لما بنعمل الكالكوليشنز للإكزام we put in our mind إنه في أسئلة مش المفروض تاخد وقت من الطالب at all، وفي أسئلة ممكن بدها calculations هاي ممكن تاخد وقت أكتر. فإحنا بنعمل الcalculations based on the questions how much I assume how much each question should take time. فبالتالي إذا أنا باجي عند سؤال نفترض أن هاي الجزئية ما درستها أو ما ركزت عليها أو now this question is consuming my time، يعني في طلاب بيقولوا كنا نقعد 5 دقائق و7 دقائق على سؤال. This is wrong. فأنتوا ب one way sequential exam behavior هذا بيستهلك من وقتك للأسئلة اللي ورا. Okay? You have to be careful when you count شو الوقت المسموح إلي أنا على كل سؤال. Okay? The other thing is when you solve questions في شيء بنقول له solving by exclusion. شو يعني؟ شو يعني؟ مثلا في إحنا عندنا سؤال بالامتحان عن ال 7+3 protocol. Okay? Before I start calculating، قبل ما أبلش calculations look at the answers، لأنه في حوالي 3 إجابات you have to exclude them directly. في إجابة كان فيها خطأ لأنه كان الأنثراسايكلين دوكسوروبيسين وإحنا قلنا إنه it's داونوروبيسين. أوكي. في إجابة خطأ لأنه التايمينج كان معكوس. أوكي. كان الداونوروبيسين 7 days والأرسي 3 days which is wrong. وفي إجابة خطأ لأنه كان هاي دوز أرسي اللي هو حوالي 1700 ملغ، وإحنا قلنا الستاندرد دوز هو من 100 ل 200. ففي 3 إجابات أنا بستثنيها مباشرة. أوكي. وthen I can make directly my calculations. فلما أعمل calculations بيكون عندي إجابتين أختار منهم. يعني أحياناً يعني how to use your time in exam is very important. المادة مو سهلة. I am telling you this is not an easy course. يعني علاماتكم is really good، وهي يعني إذا بنحول الأفريج بنحوله يعني لمن 30 مثلاً، أنتوا الأفريج من 50. Your average is higher than the regular average بالكورس. You still have 50 points for final. لسه عندكم 50 علامة بالفاينل. أوكي. يعني أنا في إجتني إيميلات من طلاب يعني دكتورة إحنا درسنا وتوقعنا أحسن من هيك. اعتبروا الميد-term exercise. Okay. Now you have some idea كيف بتيجي الأسئلة. Okay. بصراحة أنا إجاني كتير أسئلة من الطلاب بالويك إند وبالأسبوع الماضي. They really touch very important points. يعني أنا يعني I really liked their questions لأنه عم بيسألوا أسئلة مهمة. Okay. وcritical. with time رح تصير كطالب عندك تصور إيش الجزئية المهمة اللي لازم أركز عليها وأدرسها وكيف أجاوب الأسئلة. أوكي. فالعلامات is good. على علامة تقريبا هي بتطلع يعني هي 46.5، أو هي طبعا يعني على الأغلب رح تصير 50 لأنه أنتم مع يعني 0.5 رح يجزمها السيستم automatically. أوكي. فيعني علاماتكم I think is good. If you didn't do well بهذا الامتحان don't worry لأنه في لسه في 50 points. أوكي. جايين على الفاينل. you have equal weight على مادة الفاينل. اوكي، المفروض انه انتم now you can see the right answers. إذا في أي طالب عنده سؤال بامتحان المد أو مثلا مش فاهم why this should be the right answer مثلا we can give you like 15 minutes or something محاضرة الأربعاء إذا الله أحيانا. أوكي، إنه to discuss إذا في أي طالب عنده مش فاهم إنه الإجابة based on what. أوكي، فgood luck على الفاينل. I think you did well على المد، علامات is good. أوكي، واللي ما زبط على المد don't feel bad, you still have good amount، يعني لسه في علامات كتير بمادة الفاينل. اوكي، مادة الفاينل يمكن أصعب شوي، لكن still if you study the material you can score. اوكي، فرمضان كريم وكل عام وانتم بخير، وانا بشوفكم ان شاء الله يوم الاربعاء. اوكي، يعطيكم العافية. مين؟ اللي بده طيب اللي بده يطلع we are done. اوكي، يس تفضلي.
دكتورة بس تسمحي لي اخذ من وقتك دقيقتين؟
يعني يا ريت بس ما يعني مش كتير نطول. اوكي.